Hello, hello, and welcome and happy Friday, everyone. I'm just going to be keeping an eye here on as people trickle in. And I'll just formally introduce myself first. My name is Lisa Kemp, and I am Director of Programs for ATMA CENA. And I have with me today our Medical Director, Dr. Ravi Baines. So, welcome, Dr. Baines.
Thank you.
It's nice to see you. We work together and don't always get to see each other either. And I'll go. There's more and more coming in. So we've been getting a lot of interest lately. Probably, Mr. Trump's announcement and just general curiosity in social media in general about psychedelic assisted therapy. Physicians that we work with who are wondering more about it so they could recommend treatment for their clients. Other people that are interested in getting into the space, like how did we get here? Is psychedelics here to stay? We're certainly hearing it is. And so I'm expecting that we have quite a variety of people on the line today, and also those who will be, have registered and will be watching the webinar later. So we want to make sure that we open up everybody to asking whatever questions come to mind. Nothing's off limits today. We're really focusing on like what's a day in the life of ketamine assisted therapy treatment look like, and of course to a clinician it looks a certain way, to a client it looks a certain way. So we're hoping to. I just kind of prepared some questions to keep us on track, and then we'll have some time just for anybody to pop their questions into the chat or come off mute. We're happy for you to do that and just ask away. Good. Okay. All right. Well, we'll get started. So, Dr. Baines, a lot of people always want to know, like, how did you even get into this business? So I know you, for everybody's knowledge, Dr. Baines is medical director for a short stay psychiatric unit at one of the hospitals here in Calgary, and is also our medical director at ATMA CENA Psychedelics, and has done fellowship in psychotherapy as well, and obviously a real passion for doing this kind of work. So, what brought you here?
Yeah, good question. Thank you for the introduction.
Yeah.
Uh, yeah, so just really, really briefly, I did my psychiatric training in Dalhousie, and I did a fellowship in emotion-focused therapy. I'd probably have a bit of a different view or understanding of mental illness than most psychiatrists, to be honest. And I think from early on, I saw it as being primarily not prim. I mean, I don't want to oversimplify, but the people put it this way: the people that we would see with the severe mental disorders or the treatment-resistant chronic disorders, typically they would be saddled with a lot of trauma. So well, a lot of emotional trauma, repression, unhealthy defense mechanisms, which were the things that always kept them stuck. And to be honest, I've always been, 'cause I think I've been doing this for, I lose track, but probably 25 years now. And I, I've never been impressed by the effectiveness of traditional psychiatric medications. There's a small handful of exceptions, but particularly, for example, with the class that we most commonly work with, the antidepressants, I think that the evidence is actually quite poor. And at best, what they do is they're symptom suppressive on some level to some extent. Although I don't think they even do that well for long periods of time, but they do that at least. But there's nothing healing about them. And of course, the traditional way of talking about them was, well, you could use them temporarily to get some symptomatic reprieve, and during that time, the patient can, maybe do whatever other work that they need to do in order to genuinely get well. But in practice, that rarely ever happened. So that sort of cynicism about psychiatry as a profession, like as we go along, our prescribing has grown almost exponentially since I started my career. But yet rates of chronicity and substance abuse and suicide, et cetera, they've actually, if anything, only crept up. So you would think, since we're mass utilizing these, what are supposed to be safe and effective medications, you would think we would see some amelioration of the conditions that we're ostensibly treating. And that actually doesn't seem to be the case. And so I think it's because we largely, again, with some exceptions, have ineffective treatments which don't get to the heart of the matter. So, for example, there's no compelling evidence that serotonin deficiencies or, anything related to the cause of depression or necessarily even anxiety. But we've been sort of functioning under that idea for a very, very long time. And I think the consequences of that is that patients have sort of, on the whole, languished and not done well. So anyway, then probably over a decade ago, probably 12, 13 years ago, I had an experience with ayahuasca. And that was a really mind-blowing experience. And I've not only I felt that I grew and changed a lot from the experience and got a lot out of it. But also in that group that I was with happened to be with Dr. Gabor Mate, who's an interesting and complex guy. I certainly don't agree with everything that he thinks. But he is a brilliant guy, and he is a very, very effective therapist. And so in the week that I spent with him, working with ayahuasca and doing groups, it blew my mind the degree to which people were able to get past their defenses and work with previously unworkable material. And so that blew my mind and piqued my interest. But I never particularly thought that there was any likelihood that I would actually be able to ever work with these agents. And then probably 6, 7 years ago, I started reading about the ketamine literature, which goes back 20 plus years now. And frankly, I was very skeptical because it seemed like too good to be true. And it wasn't really believable, based on, all, at least when you juxtapose it with all the other psychiatric research into psychopharmacology or even psychotherapies, etc. But little by little, as I looked into it, it's like, no, it actually looks like this is legitimate. It's not a cure-all, not a miracle, but it actually looks like this seriously moves the needle. So, and then to my pleasant surprise, although I mean, it has been largely a pleasant experience, but it's been difficult because it's been because it's new and because it goes against the grain of our typical treatments. It's been a controversial area, so it was a little unnerving, kind of stepping into this field. I guess I was one of the early people, at least in the province, to step into it. Um, but it's been very rewarding, and I guess the idea. Circling back to the gist of your question, what got me interested is the reason I did the fellowship in psychotherapy was that I was always interested in trying to help get to the core, to the root of the problem and solve the problem, not just ameliorate the symptoms of the problem. And I think that's where medicines like ketamine are uh, qualitatively different from the other medicines that we have in psychiatry because they're both chemotherapeutic agents in the sense that even just ketamine, qua ketamine, will have some anxiolytic and antidepressant effects, but at the same time, they also have profound psychological effects in opening up access, getting past defenses, and getting to previously um, inaccessible terrain, which is where the trauma resides. And then people are able to have corrective emotional experiences. So that's hopefully that mostly answers your question.
Yeah, for sure. There's always a story before the story, and then the story begins again, right? So if someone who's never heard of ketamine assisted therapy, how would you explain it in simple terms?
Well, so. there's ketamine therapy, there's ketamine assisted therapy, ketamine therapy, like the historical studies that were done with IV ketamine, which showed such impressive results, at least short-term results, at least. Th That's basically a consequence of ketamine as a chemotherapeutic agent. Although psychological processes do naturally unfurl with that, but those were a side effect of the treatment in a sense. Ketamine assisted therapy, I think it's simply, um, I guess, with the acknowledgement that ketamine has these pretty profound psychological effects, and that the experience of ketamine is a psychological process. So it's guiding people through that process so that you can capitalize not only on the chemotherapeutic effects, but the psychological potential. So that's the ketamine is assisting the therapeutic process.
And some imagine it as, okay, I'm coming in, I'm going to have medicine and therapy together, but there's a lot of other components to it that aren't factored in. So how would you describe that? The before, during, and after that also, maybe bookends the medicine and therapy.
Well, I mean, you really, ideally, this is a really, what's the word? Holistic sort of approach. So, recognizing that it puts the patient, I mean, on one hand, it's a very potentially powerful therapy. Other hand, it also has risks associated with it, maybe primarily psychological risks. It puts the patient in a very psychological, vulnerable situation. So it's not like prescribing Prozac or something like that. Although I think we need to be careful with that because there are all sorts of serious problems associated with conventional psychiatric drugs as well. But regardless, with regards to psychedelics or ketamine, there's that recognition that it really does put the patient in this very vulnerable state. And the risks associated include being flooded or overwhelmed and having adverse psychiatric outcomes. So it suggests a more comprehensive, holistic approach where you take more time to understand not just the symptoms, but to try to understand the underlying dynamics, to try to understand, let's say the patient's level of ego resiliency versus fragility, to try to understand what their childhood was like a little bit, their ace experiences and everything. You want to pay probably more attention to things like borderline psychological organization, which is another term for emotional fragility, because those people may need more preparatory work to establish the goals and the therapeutic alliance. Um, and and then as you follow them through the process, again, you just sort of maintain that holistic kind of approach. Um, and it's I think also it's really this again, a lot of this is not specific to ketamine assisted therapy, but if you really want to have a good outcome, you want to make sure that you're trying to deal with things on a biopsychosocial, even a spiritual level. And that part's interesting too, because ketamine is don't ask me to define the word, but ketamine is a very spiritual kind of molecule. It lends itself to spiritual experiences, and people sometimes need help to know what to do with that. Um, so it is much more complex, I think, than prescribing a conventional psychiatric medication.
Yeah, a lot of people talk about that, preparation or set, the mindset, and then the setting, and then the types of support. And that means, to your point, like different things for all people. And just to, a lot of people say, well, how does somebody start? And we always find people have a general inquiry and want they want general information, like does my benefits cover it? And so we have non-clinical and clinical team members that all participate in that preparation and getting people ready, making sure we've managed expectations appropriately, and that they get the prep that they need. And so, and then there's that intake process after they like, okay, I don't seem to have any contraindications. I'd like to move forward with it. So if you could just briefly kind of talk about intake and what are some like absolute contraindications and to the treatment, and even what kinds of clients are we treating? Like who comes to the table, generally speaking? I get asked that a lot.
Yeah, good question. So, in terms of who comes to the table, I mean, there's no formal indication for ketamine-assisted therapy for any mental disorder. There's tentatively some indication for intravenous ketamine for treatment-resistant depression or treatment-resistant PTSD, but most of the clinics don't offer intravenous ketamine for various reasons. It becomes very, very expensive, and there actually don't seem to be any necessary benefits associated with that because the uh, change agent seems to be ketamine more than the modality of giving the ketamine. But at any rate, in terms of what's been studied, it's primarily been studied, I think, for depression and PTSD, but really it seems to be potentially helpful across the range of mood disorders and anxiety disorders. It there's a lot of compelling evidence that it's helpful for substance use disorders as well. And so the people who end up getting referred, most commonly, they're treatment resistant people with various forms of anxiety, depression, substance abuse. And they've usually failed a couple of trials of conventional antidepressants, often a lot more than a couple of trials. And they've tried conventional psychotherapy and they found that wanting, and so they're looking for something different because nothing's worked. And then there's other people too, I'd say increasingly, who haven't tried the conventional, particularly psychopharmacological approaches because they simply don't believe in it. It doesn't make sense to them. It's not something that aligns with them philosophically. So they want to try something different. Again, that they don't want to take a suppressive agent and they don't want to be on something forever. So they want to take something that is more of an expressive agent that helps them work through things. So the people who will get referred to the clinic, and then they'll have a kind of thorough intake, probably more of a thorough psychiatric assessment than you're typically going to get before you start a conventional agent. And then, of course, the medical intake as well. So, with regards to that, we've got family doctors and a nurse practitioner, and we've got nurses who do physical exams on the patients. But ketamine itself is a very, very safe agent, a remarkably safe agent, in fact. But there are some considerations. It does transiently elevate blood pressure and pulse in most people, typically not much, 10 or 20 millimeters of mercury, maybe 10, 20 beats per minute. That would be on the high side, but occasionally there's an outlier. Typically, this is a negligible increase, but in somebody who is cardiovascularly on the edge, that might be a serious consideration. Somebody who's got uncontrolled hypertension, that's a more serious consideration. If anybody has any neurological risk factors that's going to make them susceptible to increase in blood pressure, that's something that has to be taken into account as well. There's some, somebody's got active bladder disease. That could be a problem because ketamine can be an irritant to the bladder lining. If somebody's got serious hepatic or renal disease, those are considerations as well. Um, but medical clearance is generally pretty straightforward. Sometimes we'll consult with neurology or cardiology if they're involved in the picture, but typically it's a very straightforward process for a very, very well, medically very well tolerated intervention.
That's great. Thank you. And so obviously after people have been assessed and deemed, appropriate for the treatment and they're prescribed the treatment, as you said, next there's opportunity to initiate a therapeutic alliance with the therapist so that they can really assess their emotional readiness and or whether they need more preparation. So how would a therapist identify if a client is ready or maybe not yet and needs a little bit more support to get into a place of readiness?
That's a good question. That's actually, I'd say it's a little bit of a hard one to answer because it's probably as subjective as it is objective, if not more. A lot of it is going to be, I think, clinical intuition, and it is important that the therapist, not only important, but it's necessitated that the therapist have quite a lot of experience before they do this kind of work. So the therapists are pre-selected to be skilled and experienced and to be able to suss these things out. I think the first thing is to be able to establish appropriate therapeutic goals. The next thing is to be able to establish the therapeutic alliance, which is really important. Not everybody is able to be allied with. The other thing is to establish that they've got the basic parameters down in their life that are going to be able to support them through the process. We talk about safety planning routinely, things of that nature. What are you going to do if things go south? If you feel like you've bitten off more than you can chew, if you're overwhelmed. Um, and I think the therapist is going to take all of those factors into account before they decide ultimately on mostly on intuition whether the patient is ready to move forward or not. Takes a lot of trust, I think, a very trusting relationship to be able to work effectively in this area.
Very true. And it does vary, although I know I've had people say to me a therapeutic alliance in traditional therapy can, take several sessions and with people's keenness and interest and curiosity about ketamine, it seems to, and the ketamine itself really seems to help like pull that alliance together, right? Because it's really able to soften the guard, or so to speak. And so yeah, so sometimes people can typically have like two sessions and be great with that, or a couple of more general therapy sessions to maybe teach some self-regulation skills, or as you said, tools of, when they've had a big experience and opened up kind of a can of worms, and to be able to work through that, rather than move to some of the typical soothing things that we will do in when that almost autopilot discomfort arises. So yeah, and so I would add that there's a lot of teaching and orientation up front so people kind of know what to expect. And so yeah, so what do people when they ask what's it going to be like? What should I expect? How do you describe that to people?
So when I talk to people, I tell them that you're looking at probably, first of all, I tell them that most people have tend to have beautiful experiences. Some people tend to have very challenging ones, and a lot of people have both. Um, I tell them to expect to have an experience which is very dreamlike, in which they hopefully are able to let go or release themselves into. Because if they fight that loss of control, then that can lead to friction. Um, I talk about the fact that they could have it's outside chance that they could get headache and nausea and things of that nature. And we talk about how it can be frightening, and if it is frightening, how they should feel free to reach out for help if they need it, and the help will always be there, but will not be intrusive. And just a lot of encouragement to trust the medicine because it's so safe, to trust themselves and trust their unconscious that it's going to typically take them where they need to go. But it is a bit of an ineffable experience, so it is kind of hard to describe it other than, simple terms like being dreamlike or floaty. It's a very, very different experience from what most people have had.
Oh, that's fair. I've had a lot of people would say that ketamine is quite different from other psychedelics like psilocybin or ayahuasca, or even MDMA. They all have a very different effect, and some of those are more, connectedness with nature. And but you do hear that from ketamine from time to time. But what's been really more common is people describing matrix or Tetris, or that kind of seeing pixels, or um, more geometrical kind of experiences. And they often say, like, what does that got to do with what I'm working on? And I think people are sort of thinking, oh, I'm going to let myself go and be curious, and then I'm going to be told or guided or given a message, rather than this interesting, hey, I was in a box, in a box, in a box, in a box, and the box kept going. And what does
Mm.
that got to do with anything? And so I think understanding the difference between what it's doing in the brain and what it's supposed to do for you, psychologically, is difficult for
Mm.
people to understand. I don't know if you can put a little bit of context around that.
I'm not sure that I can, but I'm just thinking about one patient I had who had this really vivid experience that he was in a library and the library books were all over the floor in a disorganized mess. And they were basically, or he was organizing them and putting them back on the shelves in a way that made sense. And it's not just daydreaming. It's like it was a real experience for him. Like he felt it was actually happening. And it's hard to know exactly what that means or what the implications of it, but it's a little suggestive of the psyche sort of trying to reorganize itself in a more flexible, adaptive manner. So you have all kinds of variations on those themes.
Yeah, real,
And the
really
other thing,
big.
the
Yeah, go
other
ahead.
thing I was just thinking when you were talking is that it compared to those other medicines, it's ketamine is a very internal medicine. So I rarely do, does, I mean, I do intravenous ketamine here in the hospital. Rarely does anybody want to take their eye mask off and talk to you or ask questions or anything. They're very, very internally immersed, as opposed to MDMA or psilocybin, where they may want to interact, or like you say, they may want to be out in nature or looking at interacting with beautiful things. And so ketamine is very, very internal.
And some would even say I didn't feel like I had a body to work with, like if I
Yeah.
wanted to get up to, go somewhere. But
Yeah.
interestingly, and they'll say something would flash, and I would acknowledge it, and it would fleet. And so, like, a lot of it at a really fast speed, just things are changing, and it can be colorful, and it can be like not colorful. It could be very body experience, like, so it's really really varied. No two experiences
Sometimes
of one person are like, sorry, what
Sometimes
was
it's
that?
sometimes it's like your life flashing before your eyes.
Right. And
Mhm.
might make sense, might not make sense, might make sense in days later. And even as real, people have said, I was swimming underwater with fish, didn't need to breathe.
Mhm.
And some find that really enjoyable and fun, and other people find that really, how's that possible? Right.
Mhm.
Because it can be just so real.
What That's funny. I can't remember who it was, but the way that they termed it was learning to work with ketamine was like learning to swim underwater. And first, you might freak out and you might want to frantically, move yourself to the surface. But once you learn to get comfortable down there, then it can be a really beautiful experience.
Sure. We also had people kind of say, well, describe the clinic, or, or if they're familiar with an IV ketamine program in a hospital, how would that hospital program, IV ketamine, therapy, look different than from a clinic?
Well, the IV programs in the hospital are typically in a manner they kind of mimic ECT, so two or more typically three times a week for 8 or 12 sessions or something like that. Not necessarily associated with psychotherapy. And in the clinic, it's much more flexible. That's a very arbitrary sort of protocol. Like I say, I think it basically came from trying to mimic ECT, but there's no reason that that should be the number or even that that should be the frequency of treatments. So clinics are going to organize differently for their own pragmatics, but typically in our clinic, where I mean, you actually know the details better than I do, but we're ordering up to 6 or 8 sessions, and the sessions are interspersed with, again, they have therapy leading up to them, and then within a day, patients get therapy after their ketamine sessions to be able to process what comes up, and um, typically they're only doing it once a week. Sometimes it's more than that, but not typically. But it can be less than that. It can be once every 2 weeks. So you could be on maintenance and take it once a month, or there's some people that they may only need it, 2 or 3 times in the calendar year. Once you find that it's an effective treatment for you, it's always sort of there and able to be utilized as a flexible tool.
For sure. And in the hospital, do you guys have little private rooms and settings, or is it more like a
It's a
treatment
little,
room?
it's a little makeshift, depending on the unit. But there should be that. They're working on that, but so far the hospitals are kind of outdated in that regard.
A variation of like even installs with curtains or things like that. And
Yeah.
and people often will say, can I even just come look in the clinic and see like how is it set up? Because when you say the word clinic, they think clinic. So just for anybody listening and wondering about that, yeah, we have a private, very Zen den, like we like to call it. Each room's a little bit different, but typically ketamine people like to be in a recliner. It's very good because they can kind of position themselves the way that's comfortable. Weighted blanket, we really nest people. People bring things that make them feel comfortable also to the space that and they would have eye shades on, headphones with a specially curated playlist that mimics the pharmacokinetics of the route of administration. So it's very purposely thought out that way to sort of support stimulating those neurons. And but as Dr. Bain said, really inward experience. And in some cases, they're moving around a little bit or saying the odd word, for the most part, very peaceful and inward, and then come out and sort of try to describe the indescribable at times, and a lot of times just want to sit quiet and process for a little bit. And so that would be a psychedelic experience. And I think a lot of people don't know that we've been able to support people depending on how they're coming to the table with two different types of dosing. And so psychedelic would be that deeper experience with typically an intramuscular injection or could be IV. But we also are using low dose ketamine during therapy. We call that psycholytic. And a lot of people are kind of like, when do you use which? So how would you describe that?
Uh, yeah, I find it's a more conservative approach to start with psycholytic, because more is not necessarily better. And so with the psycholytic approach, I mean, the idea is there's a weakening of the defenses and an opening of the emotional parts of the mind. And in that context, you can do talk therapy. So with the psycholytic approach, which I think is working really well, especially since we switched to intranasal um, delivery, people are able to have a talk therapy session while they're being dosed. And then basically the therapy gets a traction that it typically would never get without the assistance of the ketamine. With the psychedelic dosing, then that's a much deeper and again much more internal experience, where the patient is typically not talkable through that process. There's no clear-cut distinction between who will benefit from what. I tend to find that the psycholytic approach makes a lot of sense. Like I say, I find it more conservative, and it makes a lot of sense. It'd be very, very powerful to be able to be guided when you're in that open state of mind. Um, so typically, we're starting there unless there's a good reason otherwise. For well, I mean, there's a few reasons it could be, but typically we'll start there. And then patients often kind of graduate to the point where they and their therapist think that, you know what, I think it would be helpful to go a little deeper. And that's when we switch to the psychedelic. Or if a patient doesn't get any benefit from the psycholytic, but typically they do get significant benefit. But if they don't, then it would be worth switching gears and going to something a little bit more, I guess you could say, aggressive. But that's how I think about it. Also, if I have a patient who is great, like who requires a graded approach, who's emotionally fragile, who's prone to fragmentation, and so forth, I intuitively think that a psycholytic approach is safer. So in those cases, we'll often say this patient is approved for X number of psycholytic doses, but no psychedelic doses unless reviewed by the psychologist with the psychiatrist and the medical team. So there are cases where I would be a little bit apprehensive about going to psychedelic.
Yeah. And even as you're speaking, there's a lot to learn and a lot to know. So we frequently get people reaching out to us to say, looks like psychedelic assisted therapy is here to stay. They've been really enhancing and expanding the research in many different types of substances, but ketamine is here right now. So for clinicians to say, there's a lot to learn. Obviously, I can refer clients to you, but if any clinician or non-clinician wants to get into this space to support people, like what would you recommend for them to do? Um, read
I
about
mean,
it?
I read about it, learn about it. I guess things like this. There aren't a lot of formal pathways. Like there's no formal accreditation or anything in this country anyway that I'm aware of. So it's really something that goes by interest learning, and then but there are informal pathways or formal informal that would be highly, highly recommended. So ATMA CENA has one psychedelic training program that I think is pretty successful and recognized at this point. That wasn't around when I started. It was more um, limited. So I did some programming with the Ketamine Treatment Center out of New York, which was a good experiential training is also helpful. So you know what it feels like to be under the influence of ketamine. There's a few institutes, a couple of prominent ones in the U.S. that give you sort of more formal training, didactic and in person that takes place over a year or two, like Naropa and CIIS. Those are very, very time consuming, and not too many clinicians that I'm aware of have availed themselves of those. But again, it's a very inter-individual thing, like because there's not a lot of formal requirements. So you're going to have to get yourself to the point where you feel comfortable. So I think one of the training programs like auras or fluence or programs like that are pretty accessible and good places to start.
Yeah, I think you're right. Like lots popping up and appealing to people's flexibility of time. And when we started, it was always very theoretical and more like what's the research saying. And then as we get practicing in the area, the training has really, really evolved. So we've recently completely refreshed the pathways and have actually three different ones: one for prescriber focused training, another one for therapists and nurses, and then another one for non-clinicians that do a lot of the work to support clients in prepping, in creating that psychological safety during the session, and then even supporting people after with integration circles. We also, I forgot to mention, we have group and individual options. So there's it's really expanding and broadening. And so I guess we have something for everyone, and then we bring everybody together to learn in scenario-based training. The reason that we
Oh,
do that
oh,
is, oh yeah, go ahead.
I was going to say also dipping our toe in couples therapy now, which
Oh
is really
yes. Yeah, couples therapies become
exciting.
extremely, like we're learning so much about that and getting a lot of really great results with that. And I was going to say we recognize that we have found such benefit in collaborating as an integrated interprofessional team or interdisciplinary team. And so that's why we designed the training to be able to bring non-clinicians and clinicians together to learn together from each other. Um, so one of the things we get asked about is if a physician or a therapist refers a client into to receive ketamine-assisted therapy, how do we collaborate with the community, with other partners in the client's care plan? If you wanted to
Sorry,
speak to that a little bit, yeah,
do you
like
mean
how do we connect with the GP when they've referred a client? How do they know? I referred them, what happened? What's the end of the story? And how can we involve them?
Yeah, I think our medical team sends a letter back to the referring agent if the patient is amenable to that, and sometimes we'll have questions for them as well, and would always be open to answering questions. Although I don't think we get that many questions from referring agents, but always open to collaborating if they feel that there's a need.
Excellent. I just answered a question. Somebody was saying, can I pop my questions in now? Yes, absolutely. I'll maybe just ask you, Dr. Baines, another one or two, and then I'd like to just open it to everybody, anything like the dosing and how do you do it and nothing's off limits. So what does a successful outcome look like? Is it very obvious? Is it more subtle? Is it quick? Is it slower over time?
I mean, it's different from person to person. Obviously, we do rate, typical standardized rating scales for depression, anxiety, PTSD. We look for reduction in those scores. I mean, typically we get them. I think the results so far have been in aggregate, been pretty positive, pretty impressive. Of course, the subjective sense of getting unstuck, or increase resumption of hopefulness and so forth. Those are probably more germane, I guess. Also, hoping you see improvements. You very often see improvements in people's relationships, their lifestyles, reduction in maladaptive behaviors, whether it's smoking or drinking or, eating junk food and that sort of thing. I think all of those things, I think that it looks different for every patient.
Hmm.
And of
Yeah.
course, many of our patients come with suicidal ideation, and ketamine is pretty well established to be helpful with that. So we look for a reduction in that as well.
Yeah, it does vary. But we've seen we do pre and post psychometric assessment scores on people, and we see clinically significant change and transformation. And I think what I love is the stories of people that they've finished treatment and haven't been back for a long time, even for maintenance, but still check in, still update us
Mm.
and say how things are going for them, which is wonderful. And I didn't experience that in traditional healthcare. I know we're going to get this. Well, we might get this question, and then I want to get to Valerie's question about some other psychotropic meds. But is it a misconception that ketamine assisted therapy replaces all psychotropic meds, and people don't have to have those medications again?
I mean, sometimes that's the case. A lot of the time, people have already tried and found wanting conventional therapies, so um, there's nothing for them to be withdrawn from because they've already withdrawn by the time they come to us. What I found is that really depends. Like I think when I was early in my career, I was always, whether it was with psychotherapy or psychedelics, I think I was really hopeful you could get a lot of people off of medications. I think realistically, what's more common is they're able to experience a reduction in conventional psychopharmacology, sometimes come off, but a lot of the people we see, whether in the clinic or that I see in the hospital, they've been on, let's say, serotonergic agents for decades. or a decade or something like that. And I think the brain in some matter almost permanently adapts to that. And so I found over the course of my career that you need to be, modest in your expectations on stopping medications and not be a zealot about it because that can cause more problems than it solves. But I would say typically, on average, people end up requiring less conventional psychopharmacological agents, and often they're able to stop.
Mhm.
Well, I'd say not infrequently, not infrequently.
Yeah, no, I think it's fair. What I've heard from some people is, gave me some level of regulation, but didn't really help the healing. So then the treatment helps the healing, and then maybe maintaining some level of regulation, but some of the other symptom management can fall away. It varies, and you go in stages. So the question that I have from Valerie is, does the dosage of antidepressants, especially concurrent medicines at high doses, affect the experience or efficacy of ketamine-assisted therapy? Things like Effexor, Wellbutrin, Adderall.
Doesn't seem like it. You might think so because they tend to be kind of numbing agents. So you might think that it might delimit the emotional experience that people have. But I haven't seen that in any kind of objective data. I would suspect that it probably has some blunting effect on the therapy, some, but certainly it's not a prohibitive sort of factor.
Yeah, I've been asked about the stimulants we've had. There's no evidence at all to suggest that it would block but we've had people that feel that it has less of effect, but not the same reports if they've taken their antidepressant that morning that it blocks. More benzodiazepines, or if somebody has used alcohol, cannabis can increase like high doses of cannabis, and some people can increase their tolerance for ketamine, so they might need a bit of a higher dose. But good, great question, and a pretty common one. And I welcome you guys to just put up your hand or write anything in the chat as I maybe just ask maybe another question here.
I think I
Uh,
saw another question in there about
oh, did you?
autism.
Oh,
Yeah.
good, thank you. I maybe we need a couple more eyes on that. So didn't see one in the chat, but I'm looking for hands, or just come off mute. Here we go. I missed. Yes, you're right. I missed. Does it help with chronic pain?
Oh, it can. That's actually a really, really interesting area. Um, I would say my best understanding is that ketamine is helpful, significantly helpful, probably in about 20% of people with chronic treatment-resistant pain, including opioid-resistant pain. So 20%, I mean, it's a sizable minority of patients, and when it is helpful, it can be very helpful. It's known to be an opioid-sparing medication, which is to say, it allows you to minimize the amount of opioids that you need to use for a patient. And also, and this is just on secondhand information from somebody who's done an enormous, enormous amount of this work. It seems to help prevent the development of tolerance to opioids. So that's really, really interesting as well. So for chronic pain, obviously, it's a different kettle of fish because you wouldn't be looking at somebody coming in. There's a different category, I guess, is specific forms of pain, like uh, the regional hypersensitivity syndrome. I'm blanking on the name right now. But for those, high doses of protracted intravenous ketamine have proven to be effective. But for other forms of chronic pain, you would be looking at daily low doses of ketamine, which is done in the chronic pain community. There's people who've been treated with daily ketamine for a decade, more than a decade, and without significant adversities or tolerance or any of those things. So I actually think it's a really neglected area that, you know, could benefit a lot of people. It's not something I've worked with primarily, but yeah, a significant, sizable minority of people, ketamine can be helpful with chronic pain.
And I also had another very fair question, trying to understand how, you know, swimming underwater with fish is helpful for PTSD. So how does the psychedelic experience and what it does to the neuroplasticity help with that subconscious matter?
So basically, what is PTSD? I mean, on a conceptual level, people are afraid of them. They're afraid of like a memory or some external cue will remind them of an experience that they had that were overwhelmed by and unable to process. And so now they have an avoidance response to anything that triggers those old, you know, largely unconscious sort of memories. And then they can have a panic reaction, fight and flight, and all of that sort of stuff. And so basically, I think I mean, if you look at the underwater, what's the substrate? Or what's the substrate? I mean, I think you're looking at consciousness, right? You're going to the deeper parts of consciousness that you're otherwise not very aware of because your mind distracts you from them because they're upsetting, frightening, whether that's somebody who had a military bad experience or whether it's somebody who had a complex trauma childhood where there was abuse and neglect and all sorts of that sort of stuff. So they're gonna learn to avoid those areas. Like a acute appendicitis and the guarding that won't let the emergency doctor put their hands on the patient's abdomen, right? So what the ketamine does is it seems to, I mean, this is how I think of it. It's a dumbed down way of thinking about it for sure, but it creates a sense of safety, which allows somebody's defenses to relax and allows them to just uh, organically go deeper. And now they're able to confront some of their, so to speak, demons, and find out that they're actually not as frightening as they thought, or they're not dangerous. It's not going to actually hurt them, and in fact, it may be helpful for them to familiarize themselves with those avoided areas. So once you start to address those areas in a more adaptive way, what you're doing is you're laying down new pathways of processing rather than just a fight and flight pathway, for example, that you're going to see with PTSD. Now you have pathways of processing in a healthy way that can confers that leads to adaptive changes in your life. And then you have the neuroplasticity that's associated with all the psychedelic agents, which allows these new patterns to take root in a way that maybe they wouldn't have been able to take before. So that's how I would, I guess, extend that analogy of swimming underwater. You're just going into the deeper and more frightening, foreboding parts of your mind, and you're developing a mastery of that, so that you have a sense of confidence. You don't have to have an extreme reaction every time the specter of those things comes to your consciousness. I don't know if that's the way I think about it. I hope that made
Mhm.
sense.
Yeah, well, that's what I was trying to say earlier. What's happening in the experience isn't always at all seems like logical, but what bubbles up after that opening of the subconscious and just having a curious experience, even in that malleableness of the neuroplasticity, even just a felt sense or an impression comes up that they can kind of bite on and kind of guides them to sort of getting into that deeper work. And so maybe a creative way of getting there, for sure. So I have a couple more questions. One related to efficacy for those who are on autism spectrum disorder, and also like, is it helpful for people that have a high degree of distress associated with terminal illness? So I'm only sharing both questions so we know we want to make time for both. And I know certainly
Mm.
you've worked with psychedelic research and palliative clients, and we've definitely seen terminally ill patients as well. So yeah, autism and existential anxiety.
I don't know of a lot of compelling evidence for ketamine with autism. I think intuitively, it may be helpful. I mean, if somebody's on the spectrum and they've got depression, anxiety, etc., I would assume that it could be helpful the way it could be for anyone else. I would think that it would be in my mind, it would. It, there's some likelihood that it could be helpful with the social deficits and social anxiety associated with autism, particularly if you do lytic therapies. So, hopefully they have more access to emotions and that might open them up more to the interpersonal experience. So that might be helpful as well. But I don't have other specific information on that. And with regards to terminal illness, yeah, I haven't done an enormous amount of that. It's not the department that I work in the hospital, and we haven't done an enormous amount in the clinic either. But I think in many ways, ketamine is an ideal agent uh, or maybe there's no ideal agent, but it's a very promising agent for people who are dealing with end of life issues. I've done a little bit of the work, and it's been pretty opening and rewarding. And I think it can be helpful on a few different fronts. So, one is it can be helpful with chronic pain, for sure. Um, the other is it could be opioid sparing, which can be really significant as well. The other is it can help break down interpersonal barriers, or it can help with, family interactions, which are so important at the end of life in particular. So help leading to some sort of resolution. And then because of the ego dissolution properties of ketamine, all the psychedelics very, very much lend themselves to reduction in the fear of death. Because it's sort of like it is like a practicing death in a way, ego death, which is the ego is the thing that seems to be so terrified of death. And so, if you can help people practice letting go and accepting, I think that can be incredibly helpful. And because it's such a workhorse kind of medication, it's so safe. It spares, the cardiovascular and the respiratory system. I mean, it's so well tolerated and everything that I think it's sort of an ideal. I think it would be an ideal tool to have in the or quiver to have in the whatever for people who are working with the terminally ill.
Awesome. We got a couple more now. So, can you just elaborate a little bit on how it can help with pattern breaking with clients struggling with OCD or disordered eating, substance use disorder? How is it helpful for breaking that?
Yeah, so well, I mean, it's very helpful, and it's known to be a pattern disruptor, which is one of the main ways I think it does help. So again, like you could talk about the default mode network, that sort of thing. I mean, that's what we call it nowadays, and then 5 years or 10 years, we'll probably have different terminology for it. But it's this sort of circuitry in the brain where the brain basically gets into a rut, and I think that. So the way I think about it, I literally think about it as if the brain is stuck in a rut in patterns of thinking which that the patient can't break, and then the ketamine can help quiet the default mode network and help George. It can quiet those pathways, and then the neuroplasticity allows for the development of again new pathways. So that's the way I think about it. But pattern disruption does seem to be one of the biggest sort of experiential effects of ketamine therapy,
Hey, I think
and
we have
with
time.
obvious implications for OCD. Yeah, which OCD is obviously more of an intractable sort of condition in general. It's very challenging to work with, but there definitely is evidence that even one intramuscular session with ketamine can be very effective in breaking OCD patterns.
Awesome. Well, I think we have time for one more, which is great. Because I got one more here. So is ketamine therapy with solely S-ketamine compared to starting with, I think it's regular ketamine, or they're
Racemic.
starting with esketamine or Spravato and then moving on to injection less effective, or does it impact the amount of time that somebody's going to be in treatment overall? So I think I don't know if you're asking specifically about Spravato versus generic ketamine that you can use intranasally, or if you're asking about intranasal. Oh yes, Bravado. Okay. Yeah. So I don't know if you want to share your thoughts on Bravado
Yeah, I'd say
versus regular.
for about probably everybody knows what it is. It's an enantiomer of ketamine, which uh, is uh, it's a proprietary sort of formulation which is used in a very specific context in a very sub-psychedelic dosing, I think 2 or 3 times a week over longish periods of time. And the indications, I believe, are treatment-resistant depression and depression with suicidality. It's actually a modality that we're planning on bringing to the clinic in the near future. And it's got some advantages that it's very, very well tolerated. And it's got a remarkable safety data because they've been studying it for about a few years now and showing really no signal for any of the scary things, cardiovascular or cognitive addiction, any of those things. So the safety signals are really, really positive with it. Uh, Actually, it's probably a little less effective than racemic ketamine for whatever reason, and it's very, very expensive, like remarkably expensive, prohibitively, really. So the people that I think it makes a lot of sense for are people who have coverage. And there are a significant number of people who, whether it's through, I guess, VAC or their insurance companies, will get covered for it, in which case it makes sense to try. Uh, but in those cases, it may make sense to try it first. If I just had to choose, which medicine to go with, all other things being equal, I'd probably go with racemic ketamine. It's more flexible, adaptable, and probably more powerful.
And we typically move in and out of the psychedelic and psycholytic and go back and forth just depending on where a client is at. So gives you a lot more freedom to have racemic compounded to the concentration you want, and then be able
Mhm.
to do and then do that at a higher dose. Some people do psychedelic therapy with intranasal, so it's a higher dose and a higher concentration. So yeah, there's just I'll just make one comment. Somebody said it's recommended that you have someone with you for the next 10 to 14 days after your ketamine treatment to assist with setting new patterns and anxiety reduction. And I just want to relay that back to how we talked about they're either doing therapy actively in that, been given tools, resources to support, and then after psychedelic, they are always with somebody in integration therapy and then working with the therapist to sort of identify what they need, which can be different things. It might be more spaced out care. It might mean that they need to come more frequently. I know we've had people knock a lot of stuff loose in one psychedelic and have 4 or 5 regular sessions. So yeah, we walk beside people where they're at. We don't like do the therapy and then do something for 2 weeks. It sort of varies. So I just wanted to quickly wrap that up and just give you, yeah, any final thought, words of wisdom, what you hope for the future in with any psychedelic assisted therapy.
No, I mean, I think we're still in really early stages. I think it's pretty accepted now, at least in the hospital environment. It's accepted that this is a legitimate treatment option, and it's losing that sort of the scary specter around it. And I think, the thing that probably is gonna be rate limiting step is that because it's such a foreign kind of approach compared to the way that we're typically trained, that until people start to get more experience with it, it's not like I say, prescribing a conventional medication, and so the uptake is going to be slower. But I think what we're going to find is that, and we are finding, is that it is not a miracle for everybody. And there are some risks, but it is significantly significantly more effective than our conventional therapies, which have really been in the big picture found wanting over the years. So, people are especially with the era of people being having more information available to them. I think people are going to probably be slowly but surely increasingly looking for what they consider to be better options, which are more aligned with their philosophies, and people who don't want to be put on antidepressants and just kept on them for years or decades. And you know, I think an awful lot of people are going to see this as a better option.
Mm. Yeah, and even just that you talked about that holistic, that whole person, mind, body, spirit. You can't, you can talk about just the medication, but those things creep in whether you ask them to or not. It's just a automatic part of all of it. And so I think a different shift in how we look at health in general, which is really great. And thanks everybody for staying a couple minutes late. I know people have to rush for lunch. It's we're still recording for a couple of minutes here for those who just want to get see it later or get the tail end of it. And but really grateful for everybody's time and attention. If you're interested in training, you can book a free call, find out a little bit more about that if you like. And we've been asked to do a webinar on okay, what's happening in the world and FDA and research. And so we're going to be covering that next month for any of you who are just really curious and want to learn more. So thank you again for
Yeah,
your time, and I hope
we
everybody has an amazing weekend.
we hope it was helpful. Thank you.
Yeah. Okay. Thanks, everyone.